In this module, we will explore the remaining MFT models. We begin this module looking at Schwartz's internal family systems model, and then move to look at the behavioral and cognitive behavioral model, the psychoeducational model, and network therapy. Lastly, I will offer you suggestions as to what you might do next in your preparation for the exam. Let's join the workshop now for the final time.
So we're going to shift now to internal family systems. And this is a relatively new model that Dick Schwartz has put together. And what it's doing is it's integrating systemic thinking and the multiplicity of the mind. Okay? It pulls from narrative, strategic, structural, Bowenian concepts. And it's really sort of merging these models into the whole world of subpersonalities. When you think of this model, think about the fact that with internal family systems, everybody has different sort of personalities within inside themselves. For instance, have you ever noticed that there's a childlike personality in you in certain kind of situations, or there's a real, stricter adult that might come out, or a more sort of analytical part of you? Okay, we all have sub-personalities. What this model does is it really conceives at the mind as an inner family, so that we're going to do therapy with an individual. We're going to do family therapy with the family inside an individual's mind. Okay? So that the core of everybody, according to the internal family systems model, at the core of everyone there's a self. And that self is sort of composed of sort of parts that have the responsibility to keep the person safe and to sort of maintain a control of both their inner and their external worlds. Now, what happens, though, is that in this model, as they develop, people somehow break themselves down, or their mind breaks their personality down into subparts. And especially if there's been something traumatic that's happened with people. So this is a particularly helpful model when it comes to working with families or an individual where there's been some kind of trauma. What happens is that a subpersonality develops called the exile. Now, the exile from the internal family systems model is somebody that, is a personality that is very young, very vulnerable, and typically in the view of the other subpersonalities, namely the manager and the firefighter, the exile is not able to take care of themselves. So what ends up happening is that this very vulnerable part of ourselves is then sort of taken over in terms of its needs by the manager and the firefighter. Now, the manager in internal family systems is that part of us that gets really busy and productive when there is pain or when there's vulnerability and kicks in. So if there's a part of you that had something traumatic happen, well, for instance, let's take the folks down in Galveston. Okay, I bet we have a lot of managers and firefighters all over the place down there. Okay, we've got people that are getting so busy and so productive and are working 23 hours a day trying to sort of make things, because what are they feeling? They're feeling that they've lost their homes, or they've lost people they love. There's just a lot of turmoil and chaos in their world. So the manager kicks in, and they're going to be working very hard so that they don't feel their vulnerability. Now, there'll be another group of people, perhaps, whose managers are not kicked in, but rather their firefighters have kicked in, and so they're numbing out from the pain that the exile is feeling. So they're using things like drugs, they're using things like alcohol, they're using television, they're acting out behaviors in order to numb out the amount of pain that the exile is feeling. Now, the point of this model is, though, that these subpersonalities end up sort of getting the person caught and stuck in their life, and that they're really not able to sort of function in the world as a fully actualized person. So what ends up happening is the self-led person, which is the goal of this model, is really not being able to sort of take that person to address the needs in particular of the exile. So what happens is that there are these subpersonalities that do not trust the self, the core self within the person. They do not trust that self's ability to take care of the pain or the vulnerability, again, of the exile. So what ends up happening is we're trying to sort of create a self-leadership approach and sort of generate the possibility for the self to again emerge and lead the person in decision-making in their lives. This model talks about the 8 C's of the self-led person. that we're trying to foster calmness, curiosity, clarity, compassion, confidence, creativity, courage, and connectedness. That these are the 8 C's of the self-led person, that when all of these aspects are readily available and a person is able to sort of embody these components, they are being self-led. What ends up happening in this model, though, is that oftentimes a manager or a firefighter gets in control of how the person lives their life, and there could be many addictive behaviors, or there could be just a level of productivity that just doesn't allow that person to access some of the pain and finish and resolve some of the pain that they experienced at an earlier stage in life. So the self is just not a passive witness state, but it's an active state that you're trying to have the person be very much engaged within themselves. That you're wanting to sort of exemplify that the self is a very confident, has perspective, has compassion, acceptance, and somehow the self has to communicate this to the other sub-personalities of the firefighter and the manager, in order for the manager and firefighter to let go their tendency to control the behavior of the self. Okay? The premise is that the self is healthy and has strong healing capacity and can really nurture and take care of the pain that the exile experienced at an earlier stage of life. Okay? Everyone is at their core a self, according to this model. Okay? And that we're really trying to make sure that we get back to the place where the self is in control or is directing things. Exiles, again, are those young parts that have experienced trauma. They tend to be isolated from the rest of the person in an attempt to protect the system for anxiety, pain, and fear. And what happens when the exile speaks is that there oftentimes is sort of, it's almost like someone, have you ever noticed, I don't know if you've ever experienced someone going into trance when you're talking to them, and they flush a little bit? They go to a different place. Well, when the exile speaks, there's a different voice that emerges as well. When the manager speaks, there's a different voice that emerges. When the firefighter speaks, there's a different voice. And when the self speaks. And what you're trying to do is you're trying to, first of all, teach your clients, if you're using this model, the language of this model. So to identify when their exile speaking, when their manager speaking, when their firefighter speaking. Okay? Exiles can become very desperate to be heard, to be recognized, the pain, and yet they feel very isolated and can't really get it out because there's not a real sense that if they let out the pain, if the person lets out the pain, that the self is going to actually be able to respond to it. And so you have these secondary responses that are attempting to caretake the exile. Okay? So the person, if just left to the exile's needs not being met, is very isolated and vulnerable and fragile. The managers kick in and they organize and run everyday life, and they do it almost in a sort of a hyper sense, where they see their roles keeping everything under wraps. And I'm sure you've experienced people in life that just have everything and try to have everyone under their thumbs. These are people that tend to have that part of their sub-personality sort of in control because they're trying to manage something else. Okay? So what the manager tries to do is to really sort of keep the pain under wraps and not sort of leaking out in other places. You know, it's just keep that person from not expressing the pain, because the fear is that once released, what would happen? It would just leak everywhere, and just the person would fall apart. So the manager tries to keep the lid on everything. And then the firefighter has a similar goal as the manager, which is to keep the exile away, or their pain or that sort of awareness away from the person. And whenever the exile gets activated, i.e. whenever the exile is in pain, that part of you is somehow bubbling to the surface, what does the firefighter do? It says, pour me another one. Okay? It says, okay, I'm going to just turn on the tube, or I'm just going to, where's the refrigerator? Right? All these addictive kinds of behaviors that the firefighter uses, self-mutilation, binging, in order to somehow numb out and reach that almost dissociative state. So the firefighter tries to sort of pull forth a dissociative state of sorts. Stages of treatment in internal family systems centers around the trying to, first of all, teaching the clients the language of this model and assessing the parts in the sequences. How do they kick in? When the pain emerges, who kicks in first? Is it the manager? Is it the firefighter? You know, in a sense, coming up with the interactional patterns within the personalities. You're looking for sort of isomorphs and polarizations between the different parts. You're also trying to sort of increase other family members to be aware of when the exile gets activated or when the firefighter gets activated, and to create some kind of a contract between these different sort of roles as to what will happen. So if the exile gets stimulated, if I start feeling vulnerable and perhaps get tearful, I'm going to sort of contract with my manager part to perhaps let me, myself, my self-led person, actually meet my exile's needs. Maybe I'll take him out for a walk. Okay, so you come up with a plan that is not just sort of staying busy, but doing something that's a healthier way of approaching and expressing the feelings in a safe environment. Okay, the theory of dysfunction centers around, with internal family systems, that life experience can reorganize these inner parts in unhealthy ways. Our job, obviously, so the theory of change is going to reorganize them again in a healthier way such that they trust the self. And that these sub-personalities get forced into extreme roles or polarizations by life circumstances that sometimes are unhealthy, i.e. trauma. Again, these sub-personalities do not trust the self. And they try to keep the pain of the exile sort of isolated, and hence it never resolves itself. It never sort of gets to a point where one heals. So the managers and the firefighters control this family of sub-personalities. Theory of change is really to transform those family members into valuable members, hence to sort of take the manager and that productivity and apply it in a more reasoned way through the self-led person, to allow sort of the intention of the firefighter to mitigate that pain, to be reformed and reframed in a way that's healthier for the inner person, for the self. And to help the self distance from those sort of less functional parts, but give voice and nurturance and caretaking to that more exile, painful part of oneself. You work with the client's self as your co-therapist, so that you're talking, in a sense, with that self to the other family members, to the exile. How do we want to respond to the pain that your exile has just used to describe how she's feeling today? What do we want to say to her? Okay? So in a sense, what we're doing is we're really separating those personalities and letting the self develop a dialogue and hence a relationship with these sub-personalities to soothe them, but also distance them from the self, and certainly from the exile. The methods, techniques, you teach the language, you develop relationships with the parts. You as a therapist have to actually sort of develop a relationship with the firefighter and the manager. You have to establish trust as the self establishes trust with these parts. You blend these parts together. Dick Schwartz talks about sort of these parts somehow being located in a body. You can sort of feel the vulnerability when people are very anxious and vulnerable. Sometimes they feel it in their chest or their gut. They can feel it in all sorts of places. You certainly would use techniques sort of like journaling. You work with the whole family that's in one's mind. If a sub-personality, you don't just work with one at a time. And you're trying to sort of have and teach the self to generate a healing place, a safe place that allows the parts, the exile, to come forth and to express the pain, and that you're working with helping the self quiet the tendency of the manager to control things and the firefighter to numb everything out. Okay? So in a sense, you're having to teach that person to parent in a certain way, the rest of everyone to allow that exile to express what's going on. Okay? So you assess things like the manager's fears. You inventory all the triggers and fears of firefighter and manager. And you're really trying to identify some of the sequences, the internal sequences that occur between the subpersonalities, as well as sort of the external sequences that occur with family members in relation to the personalities. Because remember, sometimes these personalities are interacting with other family members, real family members, not just subpersonalities inside people's heads.
So that would be the inventory that firefighters triggered, and so another member of the family's fear of triggering that kind of personality, which brings up
Yes.
their own stuff.
Yes, exactly.
Makes a lot of sense.
It makes a lot of sense, and you can see how it fits into sort of alcoholic systems and triggers, and someone that's, say, a dry drunk that has a very reactive quality to them, and so that what are the triggers? and then you'd somehow teach that language as to, okay, so what's underneath? What's the exile? Rather than the reactive part, what's the exile really say?
Or two siblings in a family system that experience trauma, and one goes to coming out, and the other goes to, control.
Without a doubt.
Then their interaction.
Exactly. When their exiles probably could talk, if there's trust enough
Yes.
with the self-led, individuals each of the adolescents, then being able to say, okay, I think we can handle this. Let's talk about it. Okay. It's very, very fascinating, and it's getting a lot of press and play these days, and well worth seeing. If you ever see Dick Schwartz come around, worth taking in. Okay. And you can even map or diagram some of these relationships. Okay. Okay. So that holds us through the internal family systems. So we're now going to shift to the behavioral and cognitive behavioral family therapy. And for our purposes, what I'd like you to do is to think of these two as being pretty much the same thing, with the exception, obviously, with cognitive behavioral, we add in the black box, right? B.F. Skinner's black box. And what is that? What's the black box? Anyone remember? Well, okay, so let me work our way up to it then. The black box it mitigates between the stimulus and the response. Okay? Something happens in the black box is basically what goes on in terms of our cognitions inside our head. Okay? But first let's talk about the different kinds of sort of conditioning. This model is important. This is a model that is based in what? The here and now completely. Okay? It's a model that really focuses on if you don't see it, it's not there. Okay? Does this model speak about what does this model do with resistance? There's no such thing as resistance. All we're looking at is behavior, reinforcers, stimulus, and if we shift up to the cognitive behavioral to the thought process or stream of consciousness, but all we're trying to do is mitigate between stimulus and response. So there are two kinds of conditioning. What are the two kinds of conditioning? Classical and operant. Which is most powerful? Operant. Okay. Classical conditioning is I ring a bell and you all drool. Salivate, sorry. But it's the idea of Pavlov's dogs. Okay. So what we do is we have a stimulus, right, or rather a reinforcer. Okay. We bring in the dog food, right. The dogs see the food, they salivate. We ring a bell. Okay. We bring in the dog food, ring a bell. The dogs salivate. We keep bringing in. Then all of a sudden we take away the dog food. We ring the bell. The dogs salivate. Classical conditioning. What's operant conditioning? Operant conditioning is that we approximate our goal behavior. And with each approximation, we reinforce the approximation. So that process is called shaping. Okay? We use either positive or negative reinforcement. We use things such as extinction in order to sort of not respond to behavior, not give any reinforcement whatsoever. We can use punishment. We are looking at baselines. Okay, pretty much a very standard sort of way of looking at things. And what we're doing in this model is really we're paying attention to sort of what the goal behaviors are. We come up with a baseline. We determine what we want to diminish. We determine what the reinforcers are going to be when we're using operant conditioning, which we tend to do. And then we decide how we're going to use the positive and negative reinforcement, and then we reinforce it to get to the desired behavior. Very straightforward. Most sex therapy, with the exception of David Snarch's work, is basically behavioral therapy. Okay? And we'll talk tomorrow more about sex therapy. Very important that you do understand sex therapy on the exam, and it's not too complicated, but the reality is there will be a number of questions on sex therapy. A quick thought is I would suggest that you make a grid of the major sex theorists, the conditions they work with, and what their techniques are for those conditions. Pretty straightforward and easy to do. You can get it from the study guide itself. Okay? So the difference then would be moving from behavioral to cognitive behavioral is that with cognitive behavioral, we're also dealing with what? The notion of the black box. And sort of what happens inside our heads between a stimulus and a response. And this is sort of the rational emotive model, REM, or RET. Sorry, REM is a group, isn't it? And And so what we're trying to do is we're trying to do things like thought stopping in this model. What ends up happening is that the behavioral and cognitive behavioral model, they really are looking again at just changing the behavior. It's very, very straightforward in terms of how we do it in terms of reinforcement. And with the term awfulizing or catastrophizing, okay, what one does inside one's head, and what would sort of a technique, a cognitive behavioral technique be to change that? Stop. Yell "stop it" inside your head. Or maybe get an elastic and snap it on your wrist when you have that kind of a catastrophizing thought. Okay? But it's really just looking at identifying sort of the behavior you're wanting to focus on and change. You get a baseline of it, you get a reinforcer, and then you sort of work towards extinguishing the behavior. Okay? Pretty straightforward model. I wouldn't worry too much about it on this exam. I think you might get maybe 5, 10 questions, but I'm guessing they're pretty identifiable. When you see it. Whenever you see just observation is one of the keys. Words like baseline, reinforcers are very, very important in terms of identifying it. So you're looking to modify behavior using rewards. You extinguish by not rewarding inappropriate maladaptive behaviors. Okay? Something to pay attention to as well are that there are 2 kinds of contracts. There's a contingency contract. Two kinds of contingency contracts. One is a good faith contract, okay, where you do something in good faith and it's not contingent upon someone else doing something else. And then there's the old quid quo pro, which is I do this, you do that. And I will only do this if you do that. Okay, which is the most trusting? Obviously the good faith. Okay. Stages are very straightforward. Identify the problem. You set goals. You design the interventions, you observe, alter the interventions or reinforcers, you terminate, brief therapy. Pretty straightforward. Okay. Stance of the therapist is that of a director, coach, very much leading the process and assessing the reinforcement and also being a reinforcer in that process too. And again, in terms of diagnosis and assessment, you identify maladaptive behaviors. You're looking for the interactional sequences where the problems are embedded. You interview to pull and tease those out. You use self-report measures, and then use direct observation and really come up with a problem-solving strategy for developing a program to address the goal you're trying to reach, what the reinforcers are going to be, how you're going to work towards reaching those goals, and how you're going to know when you've reached those goals based on what you're looking to change. Techniques, again, operant techniques, shaping, using token economies like M&Ms or stars. We use these with kids an awful lot in terms of trying to change behavior, using contracting, contingency contracts, timeouts, respondent conditioning, which is more systematic desensitization, assertiveness training, aversion therapies, sex therapies. These are all sort of related to more sort of being geared towards what's actually happening in the moment and creating different states of awareness in those moments. Cognitive affective techniques, which are, again, the behavioral cognitive component, which are thought stopping, modeling, retribution, and self-monitoring. So you're really paying attention to the thought process that goes on inside your head. Okay? So we're making our shift, and we're getting close to finishing up the primary models of marriage and family therapy that you are going to be responsible for this exam. And yes, smiles abound. The psychoed model is what we're going to cover next. And the psychoeducational model is a model that is used to do what? To teach, educate, towards what ends? To rebalance the imbalance of power and information typically related to larger systems such as medical systems and school systems and government systems. Okay? So that the psychoed model is really a model that really highlights the fact that families need information, they need knowledge, they need actual data so that they can talk intelligently with the systems they're working with or confronted with. What ends up happening is, anyone ever go to we call them in Massachusetts a CORE, which is a special ed meeting when you bring together the testing psychologist, the teacher, the expressive therapist, the guidance counselor, the SPED director, okay? And what has been your experience of the way clients are talked about while they're at the meeting? Pretty horrendous, isn't it?
Yes.
It's rude, it's disempowering, it's rude, it's disrespectful. And so what does the psychoed model tell us about what our role as therapists is in a situation like that? It's really to empower them with information of the fact, first off, that they have a say in what is being and how one is being talked about here, that people need to directly speak to me if I'm a client, and if they're not, we can stop the meeting and say, excuse me, I don't like being talked about in the third person as the mother of this child. My name is Rob Guys, and I guess I'd be the father, wouldn't I? My name is Rob Guys, and I would like to be addressed, directly. And so as therapists who work from a psychoed model, what we're trying to do is empower people to be treated as equals in situations and not accept sort of the forced sort of hierarchical sort of stance that people sometimes take in relation to people they're working with. Now, when we go to a hospital, you can oftentimes see that crazy hierarchy in a hospital between doctors and nurses and patients, crazy hierarchy. I have a little pet peeve around that. And so I've come up in my life, what I do is when I meet my doctor for the first time, I introduce myself as Rob Guys, and they introduce themselves, and I ask them, and I'm sorry, what's your first name again? And I don't care who the doctor is. And they tell me. But what that does immediately is it balances the power between myself and my doctors. And it tells my doctors that, guess what? I'm a player. And I'm going to be definitely a part of my treatment system and collaborating with you. And in a sense, that's what the psychoed model does, is that we teach our client systems ways to deal with the power imbalance in power structures in larger systems. So what we're doing is that we're trying to really give them coping skills that allow them to take greater responsibility for the outcomes of the interventions sometimes that larger systems or medical systems, when they have to connect with medical systems, have in their lives. For instance, parent effectiveness training, right? For parents that are having difficulty raising kids, or kids that are being sort of caught in situations where there's neglect, one of the things that we do is that we try to help them sort of work with, what do you guys call it out here, DCFR or something? CPS, okay. What ends up happening is, what I would do is, in a situation like that, is I would say, okay, now how can I help you get me off your back? How can I help you get the Department of Social Services off your back? Okay? This is what you're going to need to do. You need to go through this course. It's going to help you, again, reclaim the boundary around your family and not have this intervention. So what we're trying to do is we're trying to teach people how to work the system. One of the skills as systemic therapists we have is that we're able to work that larger system pretty well. We show up to meetings where nobody else shows up. We're the only therapist that actually makes other calls to other therapists. We have a lot of power when we work systemically because we're willing to do the work that other people, for whatever reason, don't do. When we do that, we can teach families how to do that as well. So the psychoed model is really trying to, in a sense, establish a collaborative partnership with the family, between the family and whatever system they're working with, but we need to teach them how to do that. We teach them how to do that with what? By disseminating information, by giving them tools, by teaching them how to advocate for themselves or bring in advocates if need be. But we're really trying to give them, if you will, an arsenal of tools and techniques to come into the interface and working with these larger systems as more as an equal, or at least as a player in the process. Okay? So the theory of dysfunction is the family has been damaged by blaming one another for causes rather than understanding the problem. So that what we're trying to do with something like anorexia, instead of have the family, or take schizophrenia, a better example. With schizophrenia, instead of have the family blame each other for who made this child schizophrenic, we look at sort of saying, hey, look, it's genetic. This comes down a line somehow from one of your families or both, and it's nobody's fault. So we give them information about that. And we really sort of look at the fact that families continue to be damaged by what we would call insensitive professionals. And the more information families have, the more they can challenge that insensitivity. And it's really important to help families sort of learn a language and learn a respectful way of challenging a system that doesn't get them in more trouble, but rather it allows them to sort of really talk with the system about what they feel to be unfair treatment. Families sometimes are unaware that there are different ways to approach things. And so you're teaching them how to sort of go about it, who to call, how to talk to people. When I was a boy and I used to get stopped by a cop, I used to get mad. How silly is that? And I used to get tickets. That's even sillier. Now, as a man, I say yes to these little young 20-year-old people sometimes if I get stopped. Not that I get stopped very often. But the point of the matter is I'm respectful, and 9 times out of 10, I don't get any. I get a warning and no big deal. But I've learned to work with the system and sort of not buck the system, and you have to teach people that. You have to teach people how to be respectful to the larger system, but to be heard. And one of the things that we know is that we can somehow work our way through the maze of bureaucracy and be heard. Now, that, of course, with the exception of any of the regulatory boards in your states that you're trying to deal with when you're trying to get a call back. That's the one area that seems, for whatever reasons, to be very difficult to break through in terms of getting sort of a response because, again, they tend to be very part-time systems and overwhelmed. But they try hard, if any of them are listening. Okay. So what we're trying to do is we're trying to sort of diminish the anxiety that happens when you feel like you're in a sort of imbalanced power battle with somebody by increasing the knowledge base and increasing the person's skills and direction as to how to proceed. So you're helping them map out a course of action. So theory of change is really you're attending to educate people and helping them sort of learn a variety of new approaches towards working towards whatever ends their meeting. If it's dealing with anorexia, we're going to teach people about the life-threatening aspects of it. We're going to teach people about nutrition. We're going to teach people the importance of working with a pediatrician or an internist. We're going to make sure that they're letting people know what the options are when they get into a very stuck place, rather than sort of just having them be at the whim of whoever it happens to be working with or whoever they get assigned to. For instance, we teach people that they can refer, if they don't like the doctor or the therapist they have, they can get a different one. But they don't have to just accept it, that they have options. So we teach people how to sort of work the system. And what we're trying to do is really sort of help them change their ideas about sort of how, sort of how hopeless they are or helpless they are in the face of working with other systems. Because people get very demoralized in working with larger systems, and they give up hope, and despair creeps in. And oftentimes we're working with families that have been sort of caught up in the system for generations, and they feel like there's no way out. And so what we try to do is help them find ways through the maze to get their needs met and to sort of, in a sense, develop another story in their lives. Story in their lives sounds like narrative.
I was just going to say, I find that probably the first 2 sessions that I have with a family that comes into the hospital is exactly this, because they don't have any idea what's going on or even what is expected of them.
Mm-hmm.
And a lot of them are involved with child welfare, CPS, whatever it's called.
Mm-hmm.
And they're really angry about that. So
Mm-hmm.
they have, before you can even actually start to do anything therapy-wise, you have to educate them on things that are going on.
So what you're saying actually is that this notion of psychoed is sort of both an engagement strategy, but it's also a piece of work that needs to be done with families in a hospital setting or a school setting that really gives them a place to sort of integrate a whole wealth of information as to how to proceed before you can even consider doing therapy.
Yes.
So in many institutional contexts, what ends up happening is you have sort of the need to educate people before you can even sort of do any kind of work with them. And that's very true in working with some of these larger institutional, these larger institutional settings, or when working with larger systems in general. Okay. So basically what we're doing is we're going to use an initial interview in terms of the stage and come up with the family's needs. We're going to have psychoed sessions, and we're going to sort of determine what needs to be taught, what kind of information they need, how are we going to actually sort of give them this information, what referrals do to other resources. In a sense, we're really doing an inventory of where they are, what their skill set is, what their knowledge base is, and then actually sort of how we're going to proceed to make sure they get to a point where they're able to sort of get their, not their intellectual, but their knowledge base needs met to deal with the larger systems. Okay. Therapist stance. Therapist provides an awful lot of information. It's active. Make sure they take responsibility of giving that information, collecting that information, teaching a client how to sort of find their way through these larger systems. Direct, empathetic, in terms of how you're working with people, and it's really key that therapy is sort of focused on disembarking that knowledge or embarking that knowledge base to them, and then it's over, and you're teaching them, though you can still be a resource down the road. Okay? In terms of techniques, it's pretty straightforward. You train the family, you set reasonable expectations in terms of what people can expect. You interpret some of the medical data if it's medical data, or you interpret testing if it's school-based. You really try to explain things. You're a true advocate. You tell family that they can help themselves. They can actually do things differently. You make contracts with families for them to follow through with things. In a sense, you're teaching them the lay of the land and how to work the larger system. And it's very empowering when done well. Okay? For diagnosis and assessment in the psychoed model, you assess the history of the problem, you evaluate the family's understanding, and then from that assessment you decide what the family needs vis-a-vis what they do know and how well they know it, also what their capacity for the knowledge is as well. And you're also looking at sort of their current attempts at coping with the situation. You don't want to suggest something they've already tried and failed at. You want to make sure that you've already sort of identified that. Now, let's talk about network family therapy or network therapy. Basically, this is a model that is really speaking to helping families in crisis, but it's a crisis of the larger system not necessarily being able to respond to the needs of someone in that family or system. What ends up happening when we think about this is that we have typically a member of the family who's in dire straits or in crisis, and the community or family is not able to respond to this person or get this person to recognize the significance of their state of affairs. And so with network therapy, we start bringing in the community in order to address the needs of this one person and get them to really shift how they're approaching their issues. You want to think about it in terms of sort of the way Native Americans approach problems on a tribe or in a tribal community. On the reservation, what they would do is what? If one person has a problem, is it that one person's problem? Is it the family's problem? No, it's the whole tribe or the whole system's problem. And they all work as a community to address the problem, so they all take some responsibility in it. This is the best way to think about the network model, which is that basically you're going to sort of look at the network effect, which is that the problem is affecting everybody. If I have a serious mental health issue, if I'm acting out all over the place, it's going to affect my family. It's going to affect each of my relationships with my family members. It's going to affect perhaps my role in my church. It could affect the way I'm sort of working with my coworkers. It could affect the person at the corner store. That somehow that network effect washes over everybody. And so what we're trying to do is that instead of sort of just noting it and commenting about it, we're starting to harness the power of the group. And the power of the group is that we're going to actually address these issues. One of the things that we're trying to do is we're trying to sort of look to where the weaker social bonds are in the group, and we're trying to sort of strengthen those. We're going to look at sort of pulling people together, the retribalization. We're going to look for polarizations and bring them closer together. And then we're going to mobilize the group to a degree that allows us to begin to sort of come up with a plan. Now, as a therapist doing network therapy, what is our role? Pretty much as a choreographer. It's not really, we don't do the intervention. We help the group identify how they want to come together and intervene. So what we're doing in terms of a theory of change, or how we think about it, is that we're going to broaden the context of treatment beyond the nuclear family to the whole community. Okay, the stance of the therapist is really, again, as a choreographer. They're supportive. We might meet with people 2, 3, 4, 10 times leading up to an intervention, and we begin to assign both roles, statements people are going to make to the person they're actually challenging or confronting around whatever the issue is. We're going to make sure all the details have been worked out in terms of if we're going to hospitalize someone, let's say we're going to get someone detoxed in a treatment program, we're going to make sure there's a bag packed. We're going to make sure there's a bed waiting for him. We're going to make sure that there is a ride and who's going to drive that person. We're all going to have individualized statements that we're actually going to speak to that person around how their behavior, how their drinking has affected us personally. and what our stance is going to be in relation to them continuing to drink, that we're not going to put up with it anymore. We're going to disengage with them if they don't follow through on this. This is a model where we actually take it to the nth degree in terms of we will take it until we break down the resistance. In a sense, it's a serious ordeal therapy, isn't it? Because we're going to break that person down to the point where they agree to then get treatment.
So does this occur more with substance abuse, or?
So it could occur with substance abuse or mental health issues. I'm actually a family therapist because we did a mini ordeal or a network therapy with my mother once after she threw one of my brothers out of the house. And I came back from college and realized that all of a sudden my family wasn't like working in a very functional way. So I called my parents' best friends over for a spaghetti dinner, and we stayed up till 4 o'clock in the morning and talked to my mother about the fact that maybe she could be wrong. And at 4 o'clock in the morning, she agreed. But we would take terms tag teaming her, tag teaming her, tag teaming her. And actually in doing so, what happened is we broke down her resistance. And then finally it allowed for a reconnection with my brother that she had thrown out of the house. So again, the point of the matter is that it's a very powerful, we pull together the important resources that are available to us. There's a sort of a use of action. We make this happen. This confrontation. We can use rituals to heighten the importance of everything. We could use psychodrama. We have a lot of direct reading of scripts. People prepare the scripts. People come in knowing they're going to be there for a number of hours. And our job as a therapist is what? To facilitate it. To really actually just hold it together so it doesn't get out of control.
Congratulations, you've now completed our intensive virtual workshop series. You may want to return to Module 1 and review the introduction to the exam and the various test-taking strategies we offer in this module. At this point, we would strongly suggest the following. First, go back through all the notes you've taken. Organize your notes. Study the other knowledge domains that go beyond the models. There is more to this exam than the models we've just covered. If you've not read the study guide, read it and take further notes. Integrate your 2 sets of notes. If you have a set of FSI's MFT audio review CDs, leave them in your car and listen to our review of the MFT models while you're in traffic. Take practice exams. Family Solutions offers practice exams on our eStudy site that will profile your strengths and weaknesses, giving you further direction in your studying. Visit the forums on www.fso.mrooms.net. There is a wealth of good advice posted by those who have taken the exam. Remember, if posting after you take the test, do not post exam questions. Once you've established your testing date, count backwards to today and figure out how many hours you need to study on a weekly basis. Stay true to this structure. It will make a difference. All of us at Family Solutions Institute wish you the best of luck on this exam. Realize, though, in order to pass this AMFT-RB exam, it takes more than luck. It takes hard studying. If you do the studying, this test is doable. Now, go to it.